think in the chat box there are some questions. Dr. Dr. Chirojit, the question tells like any experience of RVAD after transplant due to RV dysfunction rather than ECMO? Would you like to take it?
I think, yeah, I think I will answer.
If Chirojit is not there, Sanjay OP can reply. Dr. Sanjay OP.
Dr. Chirojit, you need to unmute.
Sorry, I'm here. And
oh, that's great. That's great. Thank you.
Thank you. So the thing is that, see, there are two things to it. Obviously, once you're implanting a LVAD, there's as I showed, there may be issues of septum shift, and there may be ballooning issues of the right ventricle. So at this point of time, to decide to go for a right ventricular assist device can be very challenging for the surgeon. So optimally, if you get a RVAD failure after LVAD implantation, the first thing probably would be to intraoperatively decide in your expertise of the surgeon, because that itself increases the mortality 10 times intraoperatively if you go for another assist device in the same sitting. So that is one option. If your surgeon is experienced enough and he wants to put another assist device, I mean, that may be challenging, but it is doable. But you know, there are technical issues of putting a RVAD after LVAD. So this is a team decision. The second thing, what I would suggest, that before you decide to go on an LVAD, the decision about an RVAD should be taken before an LVAD. So as Vinayak nicely showed, you know, if you do a 3D RVAD assessment before implanting the LVAD, that may be your, you know, lifesaver in that operating room that day, because you have, you know, designated software. For example, TomTech device, which we routinely use at our setup. And if you challenge with volume and see if there is a change in the ejection fraction, and if the ejection fraction, I think Vinayak mentioned a number of 24, that may be, you know, if you challenge it and see how it goes. And the third option at this point of time, I feel, if you're getting a LVAD, I mean RVAD, right ventricular failure after LVAD distension due to the RV distension, so you can put something as a bridging, you know, like a tandem or right heart assist device. And basically the primary determinants in this type of a setting, you put the RVAD as a temporary device, and then you assess, you know, the device flow, including the rotation per minute, and obviously you look between the pressure gradients of the inlet and outlet of the impeller, for example, and these are referred to as the impeller pressure head. So if you have an acute, you know, mechanical circulatory support device like RVAD, then the pressure head is determined by the pulmonary pressure and the right atrial pressure. So in the setting of pulmonary hypertension, the pressure head may be very high, which induces a reduced device flow. And on the other hand, if you have a setting of acute severe RV failure, you know, the pressure head H may be low, which increases the device flow. So it's a balance between your pattern of your device flow as well as the pressure head flow. This may be a temporary issue, and you can actually, you know, once you're in the ICU and continue it for maybe 48 hours, you tend to see how the RVAD is assisting the right ventricle. And then you can assess the right ventricle in the ICU and decide if the RV support can be, or the RV MCS can be taken out within 5 to 7 days. And that may be another way of treating this problem. But as I said, the best way is to assess the patient preoperatively and decide if this is going to be a game changer intraoperatively, because if you have a proper assessment of the right ventricle preoperatively, that may actually change the outcome of your LVAD implantation postoperatively. Thank you.
Dr. Chirojit, there was another question. We do not routinely close PFO before LVAD implantation. Is that the case? There's a question by Dr. Maiti.
Yeah. Thank you for the question. Actually, it also depends on your, you know, if it's a left to right shunt, I would suggest that you close it, because there's more chances of your RV ballooning postoperatively. And once it unmasked, you may land up with, you know, PA oxygenation, which will give you a false interpretation of the whole result. So I would definitely advise, if you are with your surgeon, to consult it. And if the shunt is really big and it looks like almost like, some PFOs can really give you a bad shunt and give you RV failure after the unmasking of the left ventricular assist device. What is important is if you have an associated mitral regurgitation, that may make the scenario worse. But only advantage is if you have a proper LVAD and there is suction on the assist device is high, you have a LV shift, and that itself, may reduce, because of the compression of the ventricles, may reduce the mitral regurgitation. But if you have issues of aortic regurgitation, PFO, and tricuspid regurgitation, it is better to advise it preoperatively. Because there are patients which we have seen in our operative setup, we have either replaced the aortic valve, or an early intervention in the tricuspid ring, or closing the PFO has actually lead to a far better outcome than just leaving it alone. Especially in cases of AI, you really need to address it in the same setting.
And I think Dr. Priya Menon, there's a question from you. How do you explain unilateral whiteout? She did explain the Cohen-Dye effect. That's the reason why there was a unilateral whiteout post mitral regurgitation. There is one more question, sir. Continue. What CVP should we aim before doing an RV assessment, before weaning from a VA ECMO post cardiotomy? I think
this is directed to which faculty?
Dr. Vinayak, sir.
Dr. Vinayak Desurkar.
Okay. Yeah, I'm there.
Sir, there is a what CVP should we aim before doing an RV assessment, before weaning from VA ECMO post cardiotomy?
These are dynamic questions. You know the CVP before you started the patient on ECMO. So obviously it's ongoing thing. And as I said, that if the RV assessment shows that the RV is functioning well, and if you are going to look at the IVC and things like that, it doesn't show you that there is excessive fluid on that side of the heart, probably you can take whatever number you have, which is suitable for the hemodynamics.
Vinayak, may I add something to that?
Yeah, sure.
Yeah, the thing is that, if you go by the literature, the cutoff number they says is below 12. But as you said rightly, it has to be, the whole clinical scenario has to be taken into mind and not looking just at the numbers. And VA ECMO, as you know, and also the VV ECMO, it reduces the RV preload by draining the blood from the RA or PA combined both. So both these systems actually oxygenate and transfer the blood to the aorta. So basically the right ventricle, if it is dilated, obviously the CPV is going to rise. And that is something, and you have to assess clinically, looking into the whole scenario rather than just taking isolated numbers.
Yeah. There is another question on the same thing. Post cardiotomy weaning of VA ECMO, what method we will prefer? RV function assessment, and how much load, CVP and pulmonary wedge pressure? I think it again boils down to the same thing, because you are looking at the heart at that particular moment. And if you find that there are less of supports, you can clamp the cannula, heart is tolerating the load for 10-15 minutes. I think that's it. So just stop the ECMO there.
And if you have really a cardiotomy, the biggest issue would be also to look into a picture of your mitral and tricuspid regurgitation preoperatively and compare it postoperatively if it has decreased. And that is probably your best indicator than looking into your CVP and your rest of the numbers. Because if you're going for a high TR and try to, wean it off, it's going to land up in disaster with a, a liver failure in the ICU. And that is something you have to keep in mind.
Hi, sir.
Yeah, Shrikant, will you please invite comments from the panelists? One comment from each of them.
Yeah.
Yes.
So I just have a doubt. I have to ask Dr. Mukherjee. Sir, I just want to know the role of inhaled nitric oxide before LVAD to reduce the PVR. Is there any role?
Yes, obviously, you have to have a preoperative assessment of how your right ventricle is doing. You have to look into the wedge pressure, and if it's increased wedge pressure, you cannot prophylactically give inhaled RO because in nitric oxide, because prophylaxis will reduce it for some time, but it will come back within the next 48 hours because you have to look into the reason what's exactly causing the increased PCWP, and that's very important at this point to determine. If you have a high MR, that will actually, by putting the left ventricular assist device, will drastically reduce it. And the right ventricular dilatation, because of the shift of the LV, because of the septal shift, may actually increase it. So you have to find a real good balance. And there is a possibility, I don't know if you're having iloprost, which is, intraoperatively, you can use it as an infusion, or inhaled NO, but inhaled NO, the limitations, if you go from 20 ppm to 40 ppm, according to literature, that's the suggested dose. But anything further increase will actually give rise to, it really doesn't add to the clinical scenario. So the use is limited, but it is definitely depending on the pathology of the patient because they have selective pulmonary hypertension depending on the pathology. And that is probably which needs to be addressed rather than going directly into the treatment.
I'd like to add here
Yes, yeah,
in Leipzig in ICU, like we had patients who were bad and who need to be going for an LVAD. Those patients, we used to put them on IV sildenafil.
Yeah.
So intravenous sildenafil used to help. As Chiro said that ileoprost inhalation and all that helps, but this one helps, really helps, sildenafil IV if you start. Because if you want to give inhaled NO, the patient has to be intubated, right? Otherwise, how are you going to give this? It's going to pollute the whole place.
Just before the surgery, ma'am, after induction of surgery.
It really doesn't help so much.
And what's the inotrope of choice, ma'am?
When coming off? Coming off?
Yes, yes.
Milrinone helps.
No.
Yeah, milrinone, we used to use a lot of milrinone. Levosimendan also we use, but never in the OT, I don't remember, but we used it in the ICU later.
Yeah, so levosimendan is, if you have written Giovanni Landoni's paper, levosimendan has a big role preoperatively as well as postoperatively, and levosimendan has actually been coming back, in the early 2010 to 15. It was almost a drug which went into, a decrease in the use intraoperatively. Now it's coming back in a big way because some studies are showing very progressive results with levosimendan. And it's very institution oriented because you really look into expertise. And the challenge is to try it and time it properly because that's going to give a better outcome rather than just starting it, just before the surgery. It really doesn't add to the clinical outcome.
Exactly.
If you have some time and if you have really 48 hours and you put the preoperative so-called priming with levosimendan, and especially for isolated cabbages, ejection fraction less than 25%, then it really helps in a big way. So that's something I think it's more you have to implement into practice more in the institution-based in consultation with your surgeons. And as a team and your ICU specialist should have at least 48 hours to prime the patient with levosimendan with ejection fraction less than 25%. Thank you very much.
Dr. Anup, any comments? Dr. Sanjay, we have very little time.
Thank you.
I think it was a very well presented series of lectures. I would just like to add the importance of doing the ramp test when you're weaning the ECMO off, wherein you introduce a little bit of vasoactive drugs. And in a stepwise fashion, you drop the ECMO flows to see what's happening to both sides of the heart. And that is invaluable while doing the final leap of faith and coming off mechanical support. Thank you again for all your lovely lectures.
Maybe one thing for ICU management, I am not aware how often this NT-proBNP is being done in ICU in Narayana or in India in general. But I feel that NT-proBNP is a very good marker pre and post-op to compare whether the patient has clinically improved. And that effect you'll probably see within 2 to 3 weeks after the assist device, or obviously if you get a transplant, that's a different scenario. But assist device in general, especially after, you'll see the drastic increase if you put a short-term NCS for the RVAD, you will see a definite change and very visible change in your NT-proBNP postoperatively.
Just to add, I think when you are coming off ECMO, you're not completely off the supports.
No.
So one should not worry about it because the supports are going to remain there for another.
So I'm talking of short-term NCS.
Yeah, no, that's fine. No, what I was saying is the main worry was the patient is going to remain on supports anyway when you come off the ECMO. So don't worry, that's your normal situation, and slowly you're going to taper those supports. And yes, BNP, I agree. As I said, even I don't put levosimendan without a BNP value because I never used to trust that is the best drug. It's not a contract drug which is going to increase like contractylitic adrenaline. So it has its own role.
And in ICU, like once you are on Milrinol or something and the patient is on ECMO for 10 or 15 days and like his pressures are okay, then we start weaning the inotropes and put him on sacubitril, valsartan or something like that, you know, these Entresto. It really helps.
Yeah.
Sir, I have just one last question to Suresh, sir. See you there. So I just want to know, do we regularly measure the SVCRA and IVCRA gradients on TE? It's a little difficult to get. Or do we do the needle pressure monitoring?
No.
And if so, what are the cutoff guidelines?
Yeah, we do measure the gradient across the IVC and SVC. Especially SVC narrowing is seen often. So when you have a PA catheter, usually the CVP, this one will be lower, but we will also put a triple lumen and the surgeons will cut the triple lumen. So the distal tip will be above the SVC. So we do measure with the CVP measured by the triple lumen is high and RA pressure or RAP measured by the PA catheter is low, then we know that there is a gradient. So then we will directly measure, and if required, the surgeons will put a patch and correct it. And IVC narrowing we don't see often because most of the time surgeons will suture the RA cuff into the IVC because there is always a competition between liver transplant team and the cardiac team. Hardly we get IVC cuff. So usually we don't measure. Only when we have some doubt like low urine output in the post-op period, liver enzymes are going, then we'll put a femoral vein and see whether there is any pressure difference between the SVC and IVC. Otherwise, we don't measure the.
Is there any cutoff value, sir? Some say 2 mm mercury and some 5 mm.
I mean, that again, depending upon the overall hemodynamics, higher blood pressure, your cutoff value may be more, but we accept 3 to 5 centimeter of water difference because it comes down in the post-operative period.
Thank you,
Dr. Shrikant, I think it's time to wind up. If
Yeah,
you can the final comments and we need to go ahead. Thank you so much.
yeah, that was a wonderful session. Thanks all presenters and panelists. I think with that we'll end the session, which was a wonderful eye-opener. Thank you all.